TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree, Chappell, your host, and we are here at Euroanesthesia 2022 in Milan, Italy. I am joined by my co-host, Monty Mythen. Hello, Monty. How are you?
I'm good, Desiree. Great to be here.
Yeah, wonderful meeting so far.
Yeah, it's excellent. With some great conversations. There's a real buzz here, lots of people around, and some great sessions, scientific sessions as well.
Yeah, absolutely. We are on the GE Healthcare booth today, aren't we?
We are. So thank you very much to GE, one of our sponsors. We can't make these podcasts free open access medical education without getting sponsorship. That's the way it works. And GE Healthcare have for a number of years now be one of our very generous major sponsors.
Yeah, so thank you to them. We're also joined by Solomon Aronson.
Hello. It's always good to be with the team.
Yeah, absolutely. Buzz in the exhibit area.
A lot of electricity, a lot of action. People are smiling and mingling and talking. Fun to see that, isn't it?
It is.
Yeah, it is. All right, and our guest today, Thomas Scheeran. Hello, Thomas. How are you?
I'm fine, thank you, and I'm glad to be back physically on a congress and to see all of you and all my friends and all my colleagues and meet all the scientists again after this, what was it, a century of COVID where we could not meet?
It feels like
The C word.
It's good to be back and to meet physically. It feels so good.
Yeah.
So I'm happy.
Thomas, you have been a guest on TopMedTalk quite a bit. I think the last time that we talked was ESA back in 2019 in Vienna.
Before COVID.
Yeah,
so, yes.
yeah, BC, before COVID. Well, Thomas, if anyone has missed that in the past, tell us just a little bit more about yourself.
So I'm a professor of anesthesia in the University Hospital of Groningen, which is in the north of the Netherlands, and I'm doing mainly cardiac anesthesia and research. So that's my research field are hemodynamics, hypotension, hemodynamic monitoring from the macro to the microcirculation and tissue oxygenation. So this is my passion.
Yeah, I was going to say, we've talked to you a lot about that.
So, Thomas, I'm just going to dive in because we've spoken, because we don't want to dominate this whole conversation about hypotension and the hypotension prediction index. We've spoken quite a lot about that in the past. But that field is moving on as more people get access to the technology, the Acumen HPI technology from Edwards Life Sciences. I think it's the unique one in the field, so we can name it as such. You did a neat study recently that I've seen presented, which I think is under review at the moment, with Simon Davis, that looked at training in the perioperative space, the avoidance of hypotension, and education compared to switching on artificial intelligence. I don't know if I've summarized that correctly, but can you give us the heads up on that study which is in the pipeline?
No need, because you perfectly summarized it already.
Can you repeat what he just said?
No, actually, yes, we did this study, which we call the Hypo IQ study. What we did, we just did not want to add another study showing that the HPI technology that you mentioned is able to reduce hypertension. There are a lot of studies showing that already. We were more interested in the psychological aspects and the aspects of how does this change the management of the caregivers. So this was the focus. And for that, we did not a randomized controlled trial, but a cohort trial with 3 cohorts. So if you allow me to elaborate on this, the first cohort was just, let's say, a baseline cohort or control cohort. We just asked them, we just told them, the caregivers, to do business as usual. So we all do goal-directed therapy in York as well as in Groningen for these high-risk patients we are talking about, high-risk abdominal surgery. And we were telling them that we were recording the data, and but not what the topic was about. This was cohort 1, and we had 50 patients included in that cohort. After that cohort, we told them, we gave them structurized education to all of the caregivers, and we said, okay, this study is about hypotension. We want you to prevent hypotension. Hypotension we define as the mean arterial pressure below 65. So please keep the mean arterial pressure above 65 by whatever you want, whatever means you think appropriate to the patients. But please make sure that the mean arterial pressure is above 65. This was cohort 2, and only before cohort 3, We gave them another structurized intervention to tell them about the HPI technology, which is able to predict hypotension early, up to 15 minutes before it actually occurs, and also gives, via a so-called secondary screen, some hints about what might be the reason behind this hypotension, so to enable you to choose the appropriate treatment for that specific cause, either be it hypovolemia, then volume would be the right appropriate therapy, or a decrease in cardiac contractility, then you should consider giving an inotrope, or vasoplegia, and only then the vasopressor would be the appropriate choice. So this was done before the third cohort, and then we looked at the incidence of hypotension in all of the 3 cohorts. And surprisingly, the results showed that only telling them, please keep the blood pressure above 65, did not change anything. So there's no significant change between cohort 1 and cohort 2. Only when we gave them the HPI technology, which predicted hypotension, and they were able to significantly reduce the amount of hypertension. So this is another study, you might say, showing that HPI technology is able to reduce the incidence and the depth of hypotension, so the hypertensive burden. But the second part of the study is even more interesting, is the psychological part. You want me to elaborate it on this?
Yes, please.
Yeah, I do, actually, because I'm like dying to hear.
Yes.
I was going to ask a ton of questions for you, but yes, go.
So we did a bunch of structurized interviews, and Rebecca Lawton from Leeds supported us. She's a psychologist doing this in a scientific, correct way. So structurized interviews with the caregivers about their opinions, feelings about hypertension, the barriers that they perceive to implementation of such a implementation, and their feeling about the technology, the HPI technology that we provided them. So first of all, we asked questions like, are you aware of the Postoperative quality initiative statements on hypotension management, and if you are completely honest, and these were anonymized questions, of course, how strict do you adhere to these recommendations? So they could give their opinion, and in the end of the day, to come to the results, so they perceived these barriers as low. They said, yes, hypertension is important. We know that we have to prevent it. We have all the tools to prevent it, even without HPI technology. So we can prevent hypotension. That was their belief, which is in discrepancy with the results that we found. So they were not able to prevent hypertension. But okay, the questions were before that. The results were obvious. The barriers that they perceived were low. They said the technology, the HPI technology that we provided them, was easy to use. It was an addition to a valuable addition to their daily management of the patients. We asked them, would you prefer a usual flow track sensor, which we use for goal-directed therapy, or to use the Acumen HPI sensor in the future? And they said, if I have the opportunity in a patient needing invasive monitoring, I would like to use the HPI technology, because it gives me more advantage over the usual technology. And they also felt that the algorithm that we provided them, based on the secondary screen variables to treat the hypertension, was easy to follow. And this was, by the way, different from a study from the Cleveland Clinic, who was negative because the doctors at that place felt that the algorithm was too complicated and difficult to follow. So in our study, it was felt that it was easy to follow.
I was waiting to see if anyone else was going to comment. Thomas, I think that's brilliant, because, one of the things that we you hear studies about, this works, that works, it doesn't work or not. But, really trying to figure out how we get adoption of new technology, new processes, new pathways, the whole thing. It's very difficult. I think you went about it in a really, really great way.
Yeah, but we have to admit it was not that easy. What I did not tell you, we had a student or a junior doctor, PhD student or something, in the OR, in all the 3 cohorts, to help them guide the technology. Because in daily life, the anesthesiologist has several other things to do, and particularly in the Netherlands, sometimes he has to care for 2 rooms.
nurses.
And so it's important that someone is there and say, according to the protocol, you now should react, or the blood pressure is approaching 65. Would you consider giving something? So just to have this reminders helps a lot, and this is maybe not something that we would have in real life.
So you referred to one of the earlier studies, Thomas, about the fact that the nudges don't always work. So there's a cultural difference that would appear in the response to the nudges. Where do you stand on closing the loop? In other words, taking the nudge one stage further and letting the computer default to give the fluid bolus, or we know all the research is happening in this space, or the drug, and you can stop it, but you don't have to start it, if you see.
Yes, this is a great improvement in technology. I understand that from the FDA perspective, this is a different type of monitoring then. If it gives you an advice or even takes actions, it's a different level of monitoring. So this is a hurdle that we have to overcome, and we need more data to show that this is actually safe and not harming the patient. And we also have to take the fear from the doctors who are afraid and saying, oh, will I be unemployed in 5 years because the machines are taking over? So this is an irrational fear, but I think this doctor is still necessary to confirm the decision given by the computers, or to interrupt, as you said, to stop it. So I don't think we have to worry about being unemployed.
I want to take us back a moment before we get into the prompts of computer activated decision making and all that kind of cool stuff that is going to come. You spoke to the adoption of the protocols in your study, in your setting, to be receptive. There was a a lower bar to overcome to get people to accept that. And that was different than others. And I don't want to get into a diminutive or critical, but why do you suppose it was adopted easier in your setting? What did you do differently? Is it a culture? Is it an education? Is it a appetite? What do you think question, because I know you didn't study it per se, but give us some insights as best you can as to why there were differences.
So as I said, in our study, we made sure that an independent study person is on site in the room not to interact on his own, but to remind the caregivers, okay, now blood pressure is this. According to the protocol, we should do this, or we should do anything. What do you want to do? So this simple reminder, or calling the person who is in the coffee room, or these kind of things. This is important. What I also want to stress, what you said is very true, because in a retrospective analysis from a different study that we did, an goal-directed therapy study, we could clearly show that only if you adopt, so if the compliance is above 85% to their protocol, we could saw a reduction in complications, postoperative complications, in those patients where the compliance was below 85%. So more than 15 times of the operation the patient spent beyond the targets of cardiac index or stroke volume variation that we defined as desirable. Then the complication rate was significantly higher. The study is published in the Journal of Clinical Monitoring and Computing 1 or 2 years ago. So compliance is indeed very important. Only if you follow your protocol, whatever the protocol is, and make sure that all the caregivers follow it, you can expect something.
It's fascinating, because what you described is the ultimate alarm. It's a person nudging you or tapping you on the shoulder, which is the pinnacle of what an alarm, I guess, in the extreme sense would be. If you take that to its extreme, knowing that we as humans have an inclination more likely than not to ignore alarms, unless somebody's literally grabbing us by the shoulders and saying, hey man, do something, then the question one must beg to answer is, should we allow artificial intelligence to supervene that which we as humans have proven to not be good at? Again, very philosophic question. I don't know that there's an answer to it, but it's an interesting observation, isn't it?
I think yes.
Yeah.
I'm trying to struggle with why we wouldn't.
Yeah.
If we keep demonstrating its potentially... I think we've accepted it elsewhere.
Right. Well, it's certainly graduated to be the norm in the airline industry, hasn't it?
I was just saying, I came here by plane, and I'm sure that the pilot trusted on his automatic landing procedure on his airplane.
Sure.
And I would prefer that over manual bumpy landing. So in that field, it's accepted.
Yeah, that's interesting.
But we have some ignorant doctors, or caregivers, I may say.
Well, we're all human.
I have 30 years of experience. I can tell when the patient is getting unstable, and I know what to do better than a computer does. And maybe... I would not say the computer is more intelligent than we, but he can learn, he can recognize patterns earlier that are hidden to our eyes earlier and give us some advice that we may consider following.
We're all smart, we're all good, we're all well-intended. I think that's a fair foundation, but we're all human, and it's our nature to ignore alarms, if you will.
Monty, you have to head out. Any last comments?
I think we were talking earlier and yesterday about wearables and remote monitoring on the floor, and the fact that if that is going to work and we're not going to get alarm fatigue, we've sort of accepted the fact that we've got to let artificial intelligence to get into that space. We seem to welcome the fact there that it will help us to filter, if you see what I mean, as opposed to nudge us to do what we should be doing. So I'm going to leave you with that thought as you go on to discuss it. I've got to dash off somewhere for a second.
Head out, but we're going to continue talking.
You pursue that one would be great, and I'll listen to it later. Okay. Sorry to be rude and dash off.
Head out. Gotcha.
See you later.
Bye, Monty.
What do you think about that, Thomas?
Yeah, alarm fatigue is indeed a problem because the HPI monitor or any monitor is not the only one in the room. If I look in my cardiac room, I have at least 5 monitors and an echo machine and a surgeon and a perfusionist, and all give me input. So, and I get tired at the end of the day if every 10 seconds someone, I have to suppress an alarm here and there and cannot even react on that. So this is indeed a problem. But we have to identify those variables which are important to us. So if we consider hypotension, sorry to come back to that topic again, as a meaningful outcome related variable that we should keep above certain thresholds, then we should react on that alarm.
Do you think that and I'm thinking out loud here, but to keep the conversation going, if I may, obviously we are highly sensitized to hypoxic respiratory, ventilatory alarms. And we are, because we've been conditioned appropriately to appreciate there's an acute response to ignoring those or delaying our attentiveness to those. There's an immediacy of response and feedback. For decades, we've been deconditioned or inappropriately taught to associate low blood pressure with the immediacy of a bad outcome. And only recently, and I'll say within the last 5 years, has that taken the fore. And perhaps it's not alarm fatigue or our inclination as humans to ignore or dismiss alarms, but we're still not fully appreciative of the adverse event that comes as a consequence of intermittent low blood pressure during the acute phase. What are your thoughts on that?
I have 2 thoughts on that. So first of all, we are also, I call it the social pressure. We are not always encouraged by our surgical colleagues to keep the blood pressure high. sometimes they even ask us for some deliberate hypotension to make their work easier, to prevent bleeding in the surgical field. This was in the past. I think we should no longer accept this. This might be one reason, and the other reason is that we do not see the consequences of those hypotensive events immediately after surgery if we don't follow up the patient. So if we just wait until he wakes up and are happy and send him to the ward and don't follow him up, we will not see the acute kidney injury developing 3 days after surgery. We will not see the myocardial injury if we don't measure the troponin. So the consequences are missed, grossly missed in the past, and only, as you said, recently we raised this awareness that we should look at those, and then we find some problems that we can prevent.
Right. Interesting challenge. I mean, the cycle of growth and education is long, but I think we have to figure out how to own it, and we have to figure out how to be held more accountable for it. And I don't think we are held as accountable as we need to be. Yeah. Obviously, if the patient turns blue, everybody turns to the anesthesiologist and points a finger appropriately often, and that's accountability at its extreme. I don't think there's that level of accountability for hemodynamic management yet.
Yeah.
No, you can't see the hypotension at the outside of the patient.
Yeah, for sure.
So,
so as a quality person, again, fascinating this conversation, and thinking about change management and how you did it. I want to go back to when you were describing the different cohorts and what you did and the support that was given. Did you find over time that those that were in the third cohort that they needed less and less reminders? The person in the room helping them with it over time, that it became just adopted and that they didn't really need that person any longer?
Yeah. So with the HPI comes a predictive, so an early alarm. So the doctors or caregivers are alarmed early, and then they don't need this ticking on the shoulder by the study person in the room. The study person in that third cohort had mainly some guidance on the algorithm in the first days, so to help you come to the right decision. Should I get volume, or should I give a vasopressor or an inotrope? So this was their role in the third cohort mainly. The alarm is given by the machine then.
Well, that was kind of my question too. Thinking about how the people, the clinicians that you were working with, did you have them actually follow up on patients afterwards?
So we do have a routine post-op anesthesia visit, usually on the next day, but still this will not detect the complications I just mentioned. So the AKI or something occurring on post-op day 2 or 3, and we did not systematically follow up these patients from the study. So we do not have outcome data for that patients. No, unfortunately.
Do you think, to that point, Desiree, that variable is key to changing behavior? In other words, to see the consequence, to see the patient turn blue, if you will motivate you to change your behavior. To see the outcome may motivate you to be more receptive to a nudge, if you will.
Yeah, we should think how we can make hypotension visible, like turning the patient green or something.
Or showing those who are managing it intraoperatively that the likelihood of adverse events, albeit troponin or renal dysfunction outcome metrics or what have you, be more evident, and to be more tethered to the badge that you wear. That I own that outcome is in part contributed to my behavior.
Well,
so what we did is analyze these patients and graphically show how many times they spent below the blood pressure and below the cardiac index and the stroke volume variation variables that we have in our protocol. And then we said, we talked to the caregivers afterwards and said, okay, see, we agreed on keeping the mean arterial pressure above 65. This is the results. So you spend 25% of the case below 65. What is your comment? And then they came with 20,000 different reasons.
Not my fault.
I was just going to say, wow.
What the surgeon did this, and the patient was too. But in the end of the day, they reflected and they said, maybe I did not do a good job in caring for the blood pressure as I should.
Is 65, is that sort of, I just saw the new Top Gun movie, so the floor that you can't fly below, in pilot parlance. Is that the right metric? Or should we be, that's obviously a surrogate for renal dysfunction or myocardial infarction or whatever end organ damage. Should we be, again, rhetorical question, talking to each other in terms of more hard outcome and having us be physicians and clinicians and providers that are a part of the team that would mitigate or bend that curve? I think so. It's my opinion that I think we're not quite there yet.
I can see, post-operatively, maybe it's that the patient's not turning green, but there is some indicator in their chart using the billions of data points that we have to give an indication of where they are on their outcomes. They're moving into yellow, their creatinine's going up, whatever, those different things, to be able to tie it back.
Yes and no. I would like to remind you that in many parts of the world, even in civilized countries, we still have paper records of blood pressure. And these are often filled in retrospectively and like a feeling. And so they have little to do with the reality. And if I may come back to this 65 threshold that you mentioned. Of course, this is a surrogate or a one-size-fits-all measure, which is not appropriate for every patient, every individual. But this is a threshold that comes from big population-based studies, retrospective studies, and it's associated with a bad outcome. We don't know even if it's a causal relation, but still, I think it's a very hard signal because it's 100,000 of patients showing that if you go under this threshold, then the risk for harm, any harm, increases, and the longer you go, the higher.
I totally agree. Get it? Agree. I accept that. My question is the world of anesthesiology providers embracing that really yet? It is a surrogate for likelihood of a bad event, and I'm struggling to understand why we have an inclination to not be compliant to those warning signals to tell us to do something. Your study demonstrated that we're not inclined to do something unless somebody's poking us in the coffee room to say, don't ignore this. And it's just, it goes back to the human nature and the sort of philosophy and psychology of change management. And so I'm waxing and waning here. I don't mean to discredit the data, which is compelling, that there is good cause to use that as a surrogate.
So the question we might ask ourselves is, why do we need a sophisticated technology like HPI to tell us that hypertension will occur? We have an alarm on every vital signs monitor. We can just put the 65 threshold alarm, or at 68 or at 70, whatever. So telling us early, we have this already. Why don't we use it, or why do we ignore when this alarm goes on, or put it at a higher range?
Yes.
So this is the question we have to ask ourselves.
Yeah. One of the things that I was thinking about as you were talking is what people are doing when they actually do treat hypotension. We've had a lot of discussion about acute kidney injury because of hypotension, But what about when people don't have an algorithm to follow, but they know hypotension is bad, so they treat it without really understanding what the problem is? And I'm getting to enhanced recovery protocols. Many of them say fluid restriction instead of goal-directed therapy, and they don't have specific, outlines for that. Fluid restriction, we know, is bad. And then they're adding on vasopressor because that's what they have in their drawer.
Well, of course you could prevent any hypotension by just giving every patient from the beginning of a case a high-dose norepinephrine drip, right?
Yes.
And we all agree that this is not appropriate treatment for the most of our patients.
Yeah.
So it is important to know the reason behind the hypertension, because vasoplegia is only one of the three main causes of hypertension that I mentioned. The other question that we might ask is, if we now have this HPI technology that tells us early that hypertension will occur, and we give a treatment like a vasopressor early while the patient is still normotensive, will this not cause hypertension, so overtreatment? And we looked at that also in our study.
Okay.
And we did not find so we looked at the threshold of mean arterial pressure, the time we did average above 100, and we did not see a difference in the three cohorts. So we did not find
early intervention
overtreatment.
Yeah.
And I think the reason behind this is we titrated the vasopressor. So if you give it early, you are able to start very low and to titrate the vasopressor to prevent a drop in blood pressure, but not to get an increase in blood pressure. If you would give the same treatment as you would give in a hypotensive patient, a big bolus of phenylephrine, for example, then you might get this overtreatment reaction, but not the way we did it. So it is safe.
Well, one thing that I find, sorry, 1 second, Saul. One thing that I find interesting with the acumen and the parameters that you get, there is more information than just you may see hypotension in the next time period. There's some other indications, right?
Yes, so I find this, what they call the secondary screen, even more useful than the fact itself that there will be hypotension, because this helps you treat your patient appropriately. So I leave the secondary screen open all of the time to see these changes, because it's applied physiology at the bedside that you can look at. You see variables like the DPDT, so the measure of the contractility. We don't deep dive into that right now, but this is what I find interesting. And now we know, for example, that all the anesthetics that we use have a myocardial depression effect.
Yes.
And now we can see it.
Yes.
We can see the number going down the first time. So I find it very, very exciting, and I'd like to look at these things.
Yeah, sure.
Do you think that if you would have looked at essentially your second cohort again as a fourth cohort, sandwiched, post third cohort, behavior would have changed?
That's an interesting question. We didn't think about that. So I have an idea when I come home.
Excellent.
New project.
Something for everybody.
That's right. Well, Thomas, I want to switch gears switch gears just a little bit, and for the remainder of our conversation, for a couple minutes, talk about, we talk about intra-op hypotension, about post-operative hypotension, and some of the other untoward things that we see happen post-operatively, because we know, surgery is pretty safe now, anesthesia is pretty safe, but post-operatively we are, having issues there.
Yeah, this is a real issue that you raise, because when we look at the data from the USO study, for example, outcome study performed in Europe, almost 50,000 patients, we have to realize that 95% of the patients do not go to an intensive care or high dependency care unit after surgery. They go to the normal ward. And the standard on the normal ward is no continuous monitoring. You have your blood pressure and saturation and respiratory rate and temperature monitoring once a shift, or at best every 4 hours.
Yeah, maybe 4 hours.
We will, and maybe less at night.
Yeah.
So we will miss a lot of these vital signs deteriorations on the normal ward. Yeah. And there's a study from the Cleveland Clinic who looked at those, also in abdominal surgical patients, and they said it was about 25 of the patients, when they did measure continuously, so every minute they measured blood pressure instead of every 4 hours, they could see that a quarter of the patients, so 25% roughly, had more than 30 minutes below a mean arterial pressure of 75, and another 5% or 15%, I can't recall the exact numbers, had a mean arterial pressure below 65. So large amounts of hypertension occurring postoperatively, which are missed by routine vital sign monitoring as we perform it nowadays. So there's a lot of room for improvement to increase the safety of our patients, because for the hypotension, it does not matter when it occurs, intraoperatively or postoperatively. Hypertension is a bad thing, so you should prevent it anywhere in the course of the patient. And if the patient recovers from surgery, he should also be observed closely to avoid these problems.
Yeah. Well, Thomas, thank you so much for joining us. It is always such a pleasure to talk to you. I love what you're doing. I can't wait to hear about your new project whenever you go home. And we will catch up with you again soon. Thanks so much.
Thomas, good to see you again.
Yeah.
Thank you very much.
Yeah, thanks so much.
Okay.
Thanks so much for listening to TopMedTalk. You know, you can always find us at TopMedTalk.com. All of our great conversations from Euroanesthesia 2022. We are on your favorite social media platforms, LinkedIn, Facebook, Twitter. We are there. Be sure to check us out and comment on some of our conversations we've had over the last couple of days. And we will talk to you soon. Cheers.
Ciao.
Desiree Chappell with TopMedTalk. It has been an exciting year, and there is so much more to come. Now I'm joined here with Monty Mythen. Monty, what is coming up?
Well, next, TopMedTalk are going to be coming to you live from the European Society of Anesthesiology from Milan in Italy. You'll find us on the GE booth in the trade exhibition. We'll be there intermittently, and we'll probably pop up in a few other places. So I'm there with Desiree, and Sol Aronson's coming in, and Henry Howe. And after that, Desiree, where do we go?
It is time for the 25th anniversary World Congress of Perioperative Medicine in London, right? Live.
From the UCL campus to celebrate our 25th anniversary. So that's really exciting. And then I think we've got the next one in August with your organization in America.
It is. It's in Chicago. It's the American Association of Nurse Anesthetists. Monty and I are going to pop up there, have some great conversations, and then it's on to
Dingle. So that takes us into the autumn and winter season. More about that to follow.
And then, of course, we're going to be rounding out the year with the American Society of Anesthesiologists in New Orleans for their annual Congress. So super excited about all the events for the year. Don't miss us. Be sure to check us out on TopMedTalk.com and on your favorite podcatcher. We are there with late-breaking anesthesia and perioperative news. Right, Monty?
Absolutely. See you soon.
Cheers.